cardiovascular disease, liver disease, malabsorption, and other endocrine disease, and using of tricyclic antidepressant with the type of hormonal replacement therapy with menopausal symptom in women. So our aim to evaluate the significance of a Q fracture score in women aged between 45 and to the 75 years, and the presence of vertebral fracture by examining the sensitivity and specificity of a Q fracture score. This study was performed during October 2009 to July 2011. And this subject was selected from the outpatient attend the consulting clinic in Al Yarmouk Teaching Hospital and rheumatological clinic in National Diabetes Center of Al Mustansiri University College of Medicine. We have 153 female were included in this cross-sectional study with age between 45 to 75 years, and the Q factor was calculated through a questionnaire form for all women enrolled in this study to determine the probability of a fracture in the next 10 years. The value of a Q fracture score was predicted using the data from the questionnaire using the website that found in this page. We asked about the 16 risk factors that we said before. Lateral X-ray of the thoracic and lumbar spine were taken for all women of both groups, which is called according to the clear-cobalt method. And this method consists of naked eye inspection of vertebra from the fourth thoracic to the fifth lumbar, comparing each vertebra to the vertebra below and above. And if we found an abnormal vertebra, we measure it by a ruler. This is the clear-cobalt method. The first one was normal, the second one end plate deformity, the second one anterior wedging, and the fourth one was complete compression. We found that 30.7% of women have vertebral fracture, while 69.3% of women have no vertebral fracture. So we can say that 1/3 of the female have vertebral fracture and 2/3 have no vertebral fracture. This is the distribution of the presence of vertebral fracture according to the probability of the Q fracture score within the 10 years. We found that the mean of the Q fracture score in women that have vertebral fracture was 15.36, standard deviation 5.6, while those women without vertebral fracture was 4.89, standard deviation 2.37. The Q fracture score ranging between 9 to 33 in women with vertebral fracture, while those without vertebral fracture ranging from 0 to 11. There is significant correlation between the presence of vertebral fracture with the increasing of age. Regarding other fracture risk, we have when there is lower body mass index, there is significant correlation. When we have steroid intake, there is significant correlation. When we have history of fall, there is significant correlation, while other like smoking, asthma, and angina or TIA have no significant correlation. Other was chronic liver disease have no significant correlation. Rheumatoid, no significant. Just in endocrine causes like thyroid toxicity, we found that there is significant correlation. Correlation of the presence of vertebral fracture with the hip fracture only, we didn't find that there is significant correlation. The log curve showing highly sensitivity and highly specificity of Q fracture score to predict of the presence of the vertebral fracture. From it, can we get cutoff value of Q fracture score when the cutoff value of probability of fracture was equal to 8.5, give us 100 sensitivity and 92.5 specificity. So, however, Q fracture could be used to select high-risk patients for bone mineral density measurement as a part of their assessment following identification of their high-risk status for fracture. Finally, there are significant correlation between the presence of vertebral fracture with the increase of age and decrease lower body mass index, steroid intake, and falls and thyroid toxicosis. Conclusion, this score can predict risk of a fracture in people without laboratory measurement and is therefore suitable for use in both candidates and for self-assessment. A cutoff value of a score equal to 8.5 can highly suspect to the presence of vertebral fracture. Thanks for God for giving us ability of thinking and searching. Thanks for God, and then thanks for His messenger Nuh, Ibrahim, Moses, Jesus, and finally our Muhammad, to teaching us wisdom, good behavior, and ethics and moral. Thanks for you for listening.
Okay, Dr. Ahmed, thank you. Any questions? Further.
I must say this is a very interesting topic. My question is, did you compare the facts to the Q scoring?
The Q fracture score. There's this that published in the GMA. GMA. There is a prediction of Q fracture score comparing to the facts. So they do it. Why I do it? They do it. That doctor who newly do the Q fracture score in the beginning, he was comparing facts with the Q fracture score. So they present it as.
Why I'm asking this question? The facts is definitely shorter and easy to fill than the Q score. If we discover more patients in the Q score, this is justified.
The Q fracture score, Q fracture score doesn't need bone mineral density. So bone mineral density. So they can use in the GP clinic where they can do the probability of fracture. While while the facts, we must need bone mineral density to detect the probability of a fracture. And this is the research that do the comparing of the facts with the new algorithm which is called Q fracture score.
Okay, thank you, Dr. Ahmed. This is your